little bit of a different approach with this webinar. Here we're talking more about, in process, kind of where cancer comes from. A lot of times when you look at cancer, playing armchair quarterback is very difficult to do, and really focusing on some of that, causation, if you will, doesn't really help us a lot in treatment, but it does in help us understanding where it came from and really how to direct treatment. Sometimes you can determine causation after the fact, sometimes you can't. And looking at infectious diseases or infections as causes of cancer is something that often gets overlooked in what contributes to cancer. Everybody talks about toxins and toxicants, but infections are just something that kind of slips underneath the radar, especially in Western countries. So here at Brio-Medical, we are a natural, holistic, integrative cancer healing center here in the beautiful state of Arizona and the beautiful city of Scottsdale, Arizona. Here we focus on not just targeting the tumor, but healing the body from a physical, emotional, psychological, and spiritual standpoint. I am the medical director here. I'm both licensed as a medical doctor and a medical doctor homeopath. I've been medical director here in Arizona at a holistic integrative cancer center for now 5 years. I've been in the integrative movement since 2006, published a couple books, and speak around the country and around the world on wellness and integrative cancer topics. Here at Brio-Medical, we really focus on the broad aspect of how we can bring together different therapies, sequence them together, and really be precision-based in the treatments that we use to target cancer and heal the body. And these are just a few, and a list of a few of the therapies, of many of which we can use to actually target cancer and heal the body simultaneously. Do some more therapies, of course, hyperthermia, photodynamic therapy, photobiomodulation. These are all critical aspects of treatments that we will use, not with everybody, but with many patients to target tumor and heal the body. So when we talk about infectious disease and cancer, I want to really highlight 5 areas. There's the obvious viruses, bacteria, parasites, and then there's the less obvious fungal, and then I want to touch a little bit on biofilm, because I think that'll bring some different concepts to the front that I think really is going to change the way we view how this process of infection can contribute to cancer. Now, when you look at a lot of the literature, the numbers vary, but viral infections are estimated to cause up to 15% of cancers. There are 3 primary parasites: schistosomes, Opisthochus viverni, and Clonorchis sinensis, not sepsis. It's an autocorrect error. Are classified as class 1 carcinogens. And so looking at these 3 parasites, they are estimated to cause 0.4% of all cancer types. Now, depending on the area of the world that this is in, it's a bigger impact. Collectively, some research suggests up to 25% of all cancers are caused by infectious disease. And if you think about that, that's a huge number. Other studies will put that number lower at 14 to 16%, but somewhere between 15 and 25% of all cancers can said to have a infectious cause. These are just a few graphical snippets of slides that I gave at the talk down in Clearwater, Florida last week. And we have to look at this process of cancer because in many ways inflammation, so pre-existing inflammation, is the bed in which cancer lies. Now, the story doesn't end there, but this is critical foundationally to how cancer develops, thrives, and survives. But then what happens is cancer turns around and contributes to this inflammatory process, and in fact disrupts the inflammatory process, uses the immune system against the body for its own benefit. Here, it's tumor-elicited inflammation. Obviously, infection is going to be playing a role in inflammation, causing cancer, but this is going to precipitate this cascade, this snowball that rolls downhill, if you will. Now, when we look at cancer, the narrative out there on cancer is that we're winning the war on cancer. Yet here you're looking at a graphic published out of the LA Times, looking at government data in NCHS, actually showing that really looking at cancer as cause of death is really approaching that of heart disease. So when you look at that, it's like, well, that number has continually trended up. But then when you look at additional US data, here we see on the left, the annual rates of cancer deaths from 1999 to 2016 decrease. Well, that's good. But at the same time, the annual number of cancer deaths over the same time frame went up. So that just doesn't make sense. The annual rates of cancer deaths go down, yet the annual number of cancer deaths go up over the same time frame. Yet at the same time, 21 states in the United States, cancer is the #1 cause of death in adults. So when you put these all together, you really have to question, are we really winning this war on cancer? And the answer is no. Infectious disease is playing a role in this. In other areas of the world, it's much bigger than here in the US. That's why it often gets missed. And there'll be a little bit of a topic we'll touch on through this talk that really touched on the last 2 years of all of our lives. And I think the implication there, as most of you may be aware, is concerning. I talk about this study quite a bit. It's the Prospective Urban Rural Epidemiology Study, the PURE study for short, that's the acronym. It was looking at basically, they were evaluating the differences in incidences of common diseases, hospitalizations, and mortality in adults. And they looked at high-income countries, middle-income countries, and low-income countries across this study. And what they found is that in the upper left there, the upper right, what you see here is you see the actual high-income countries, and that kind of pink color is cancer. And so in high-income countries, what you see is that adults, the #1 cause of death is cancer. Not cardiovascular disease, but cancer. When you look at middle-income countries and low-income countries, you see that other disease states that have been typical in Western type countries dominate. So middle-income countries, cardiovascular disease remains #1, cancer drops to #2. But when you move up into the higher income of the middle income, cancer actually starts to move closer to that. So when you look at countries like the US, the UK, etc., Sweden, Norway, cancer is the #1 cause of mortality in adults. And again, it's estimated that up to 25% of all cancers have an infectious cause. Africa, Asia, that's what really dominates that number and really shifts it higher. In countries like the US, it's lower. Yet, I'd like to talk about how cancer is a disease of lifestyle, but we forget that infectious diseases can play a significant role. And over the last couple of years, that'll make it more relevant for us and really the rest of the world. When you look at infections and cancer worldwide, greater than 90% are caused by 4 things infection-wise. Helicobacter pylori, this is a bacteria that's associated with gastric ulcers. It significantly increases the risk of developing duodenal and gastric diseases and gastric cancer. So this is very significant, and this is important because gastric cancer is the second leading cause of cancer-related deaths worldwide. Of course, HPV, human papillomavirus, this has significant contribution to cervix, oropharyngeal, anal cancer, vulvovaginal, penile cancer, and it's been associated with more than 90% of anal cervical cancer, 70% of vaginal, 70% of oropharyngeal, and 60% of penile. So significant association there between the high-risk HPV. These are typically 16 and serotypes 16 and 18, 33, 35. So there's specific types of HPV associated here. Hepatitis B virus, it's been implicated in about 80% of causes of hepatocellular or liver cancer. It comes from food, hepatitis C, which can come from transfusion, surgeries, etc. Significantly associated with liver cancer, B-cell non-Hodgkin's lymphoma, and other types of cancer. So 90% of all infection-related cancers worldwide are caused by these 4 infectious sources. H. pylori, very prevalent here in the US and Western countries. HPV, obviously very prevalent. Hepatitis B and hepatitis C, clearly prevalent. So the concept and the topic of infectious disease, though a lot of infections that we think of that relate to like parasites and other things, Asia and Africa, which we'll touch on, but here 90% caused by these 4 right here in the good old US of A and in Western countries. So this is relevant, and this is very intertwined with the cancer rates here in the US. Now, when you look at group 1 carcinogens via the International Agency for Research on Cancer Biological Agents, they listed several different infectious sources that are group 1 carcinogens. Most of the cases here, we think of things like glyphosate, we think of things like cadmium or mercury, but here we're talking about infections, EBV, Epstein-Barr virus, hepatitis B, C virus, as I mentioned, Kaposi sarcoma herpes virus, HIV, human papillomavirus, human T-cell lymphotrophic virus, a couple different parasites, Opisthochus, Clonorchus, which we'll touch on these, schistosoma, and then there's that bacteria, H. pylori. So when we talk about carcinogens, we think of chemicals, and rightly so, but understand these also are labeled as carcinogens, but yet they're infections. So let's first talk about viruses. Again, the numbers will vary here, but it's pretty consistent. Somewhere between 14 and 16% of all human cancers worldwide can be attributed directly to viruses. Now, this is both DNA and RNA viruses. And this is huge because viruses are one of the most easily transmitted infections that we as humans can encounter. So viruses, of the 25% estimated worldwide, viruses are going to contribute to really 60 to 70% of all infectious sources that are capable of causing cancer. What's happened over the last 2 years? A virus, maybe? So when we look at the implication of the viruses in cancer, there's several here. I've already touched on a few. Human papillomavirus, Epstein-Barr virus, HIV, hepatitis B, C, Kaposi sarcoma, human T-cell lymphotrophic, and then Merkel cell polymovirus. Now, the cancers implicated from these viruses include things like Burkitt's lymphoma, cervical cancer, vaginal cancer, anal cancer, penile cancer, Kaposi sarcoma, and nasopharyngeal cancer. So you can see viruses are implicated in very specific types of cancer. So when we look at here, HPV, that's obviously implicated in oropharyngeal, cervical, vaginal, EBV, in Burkitt's lymphoma. So these are very, very specific in their connection of cause-effect. There's also associations. So again, viruses play a significant role and are a major contributor to infectious causes. So I would be amiss if I didn't touch briefly on SARS-CoV-2. Of course, this is a causative virus in part to the COVID pandemic. And when we look at this is a virus. This is a pathogenic virus. All the previous viruses I just mentioned are pathogenic viruses. And when you look at SARS-CoV-2, it has a direct connection via the spike proteins to cancer. And it's many other ways, but it's primarily through the ACE2, angiotensin II converting enzyme receptors. And this also brought forth a lot of media attention that they were focusing on how to block this, because this is the portal, the primary portal of how this virus would enter into the cell. Interestingly enough, many different cancer types overexpress this angiotensin converting enzyme type 2 on its surface. So that is why not only do cancer patients typically get worse with infection, but they also tend to get worse with injection. And it's because of the spike protein is allowing entry and promoting inflammation and promoting many of the pro-growth, pro-inflammatory pathways that you see cancer use to grow. And SARS-CoV-2 contributes to that. And when you look at many of the comorbidities that are associated with SARS-CoV-2, these would be risk factors that increase risk of mortality. They are things like obesity, advanced age, diabetes, hypertension, and cardiovascular disease, and cancers listed there as well. What's interesting, all of these are chronic inflammatory disease states. Advanced aging is not, but inflammation increases with age. But every one of these otherwise is. So there's a common connection, but there's also a thread how the virus here, this pathogenic virus, will actually promote cancer, and I believe it's going to make the cancer prevalence and incidence spike. And I've actually seen patients either through infection or injection really have a cancer that was controlled or in remission just go absolutely haywire. And there's a lot of literature support to the mechanism of how that happens. So what might the future hold? The future that we're concerned about, we're actually starting to see. So how in the world could SARS-CoV-2 be implicated in cancer? Well, there's specific mechanisms here. I don't want to theorize this. I don't want to just provide conjecture. I want to provide specifics. We know that SARS-CoV-2 stimulates nuclear factor kappa B. This is a major driver of inflammation transcription. This is how the genetic code gets upregulated to produce inflammation. This is key in the viral implications in infection, but it's also key in how it contributes to cancer. It turns on chronic inflammatory production, pro-inflammation signaling, and cancer loves this, and it takes it and runs with it. You probably heard a lot of people talk about cytokine storm. That's integral there as well. Everybody focuses on spike proteins, rightly so, but there's other types of proteins involved in the SARS-CoV-2 virus. There's a nuclear capsid, but then there's also a membrane protein. And this membrane protein has been shown to induce the mobility and proliferation of stemness of, here, example, triple-negative breast cancer cell lines. And this is via the upregulation of that same inflammatory transcription in STAT3 pathways. So here we're not talking about spike protein, which is kind of what I referenced in the initial slide, but here we're actually talking about another protein, a membrane protein, actually promoting mobility, which is how cancers become metastatic, but then also stemness, stem cells. That's how cancer basically recurs and metastasizes and becomes resistant. T lymphocytes. There's several different types of T lymphocytes, but lymphocytes are part of the innate immune system that we need to really target enemies, both foreign and domestic, and cancer falls into the domestic category. COVID-19 induces apoptosis of both CD4 and CD8 type T lymphocytes. Of course, this is in patients with severe symptoms, but this results in lymphopenia. This is a suppression of lymphocytes, suppression of the immune system. So if a patient has cancer and you suppress their immune system, what might one expect to happen? Cancer grows. And that's exactly what you see. And those lymphocytes that remain, you're going to actually see decreased activity in those. They become lazy. They don't work well. So this is viral. And this HIV did very similar processes as well. So again, pathogenic viruses are going to have a very similar effect here. That's why the estimation, the implication early on with this new virus was that it was going to increase cancer rates, cancer progression, cancer aggressiveness, because that's been the repetitive pattern of pathogenic viruses throughout history. Further implications, I mentioned the cytokine storm. This is that cytokine burst, that inflammatory burst associated with the SARS-CoV-2 infection. This is actually what was creating a lot of the damage and more mortality and morbidity associated with it. Interleukin-6 is an inflammatory signal. We also know that this contributes to cancer growth and cancer metastasis. For example, maximum tolerated chemotherapy, so full dose chemotherapy, provides aggressive interleukin-6 stimulation, cytokine storm, and this causes a metastasis. The literature is very clear on that. It's repetitive in its nature, and so this is one of the mechanisms also by which the SARS-CoV-2 cytokine storm through interleukin-6 is going to contribute to the pro-inflammatory pathway that's going to contribute to cancer's spread. And I've got the references down there for you to read. So if you've got insomnia tonight, open those up and that'll correct that. Just kidding. That'll keep me awake. JAK-STAT pathway, another key pathway involved in really cell growth, proliferation, and invasion. This is it's internal cell signaling that are normal pathways for our healthy cells. But here what happens is you get hyperactivation of this JAK-STAT pathway, and the cancer basically uses something that's normal and healthy in a way that's unhealthy but sustaining to it and detrimental to us. So again, we're not speculating here. Research repeatedly is showing this. Platelets, this is a big area of concern. You know, they talk about the immune suppression of platelets, but we also know that the spike proteins and other signals also increase and hyperactivate the platelets and actually really promote a increase in what's called the cancer cell platelet aggregate. So if you come in with, say, chemotherapy and you release out circulating tumor cells as a result of that treatment or surgery or radiation or just a normal process in cancer, these circulating tumor cells will surround themselves with platelets. And this provides a buffer in this cancer cell platelet aggregate, and that keeps the immune system out. Interestingly enough, vitamin C will come in there and break up that cancer cell platelet aggregate and allow natural killer cells to get in there. But we know that the SARS-CoV-2 infection promotes platelet hyperactivity. It also damages the endothelium, which is the vascular cell lining. And so if you want a cancer cell to reach a new site and invade and set up a new secondary metastatic site, it's exactly what you would want to do. Hyperactivate platelets, surround it in the cancer cell platelet aggregate, damage the endothelium, and that's going to allow those hyperactive platelets to land on that endothelium, what's called extravasate in, and form a new site of cancer. But I don't want you to think here that all viruses are bad, okay? There's actually what are called oncolytic viruses. These are non-pathogenic viruses to humans, and here's a study called high-dose vitamin C plus oncolytic adenovirus enhance immunogenic tumor cell death and reprogram tumor immune microenvironment, which I've mentioned before, but I wanted to not really create a black-white issue, but say, hey, depends on the virus type. Previously, I've been talking about pathogenic. Here, I'm talking about non-pathogenic. Here, an oncolytic virus can actually be used in conjunction with vitamin C to actually reduce what's called macrophage polarization, which is a key concept of how the immune system becomes dysfunctional and disrupted and turning on the body, not the tumor, in specifically the tumor microenvironment. I'm a big fan of oncolytic viruses. We use Rigvir, but there are a couple other here in the US. Bacteria. So viruses are probably the largest player of infectious sources. Again, probably 60 to 70%. But here we're talking about bacteria. And again, very, very strong evidence here links, again, one of the 90%, H. pylori with gastric cancer, but also esophageal cancer. Here also talking about mucosa-associated lymphoid lymphoma. So many different types, but H. pylori is not the only bacteria implicated in causing cancer. Others implicated, of course, H. pylori, Salmonella typhi, not a bacteria we tend to see a lot of here. It does occur from time to time. Streptococcus bovis, chlamydia pneumonia, this is one we see more often. So we can't look at bacteria and say they're devoid of contributing to cancer. But here, as it compares to viruses, they are going to be definitely a lower percentage base, but still nonetheless very much implicated. And probably here in the US, we're looking more at H. pylori and chlamydia pneumonia as a major contributor. Salmonella typhi would be something we see more outside the US, though that can definitely occur here with foods being produced outside the US brought in. Cancers implicated would be cancers like gastric cancer, lymphoma, gallbladder cancer, colorectal cancer, esophageal cancer. A lot of the locations are really dictated by the type of bacteria. Obviously, implicating H. pylori is a major driver, as it's one of the four in causation of 90% of infectious contributors. I've been doing a lot of reading and research on biofilms. These are the powerful yet misunderstood, and really most people are unaware. It's just a biological film that really kind of interconnects bacteria and interconnects viruses and parasites. They're all a part of this environment, this milieu, if you will, that exists really throughout the body in different areas. So it's accumulation of microorganisms of mono or polymicrobial aggregates, commonly referred to as a biofilm. Most people think of this in reference to Lyme disease, Borrelia burgdorferi, but understand this concept exists in many different areas really throughout the body, environments, but also biofilm is not all pathogenic. It also can be healthy. It coexists in diverse communities of bacteria and fungi. The close proximity of these microorganisms enables basically communication, metabolically, protection, immune system aversion. So this is really a kind of interconnectivity, a network, a shield that these organisms will use to protect itself and attack the body. So what is biofilm and why is it important? Well, again, when we think about infection, which the title of this and the purpose of this webinar is to talk about infection, we have to understand that it's not necessarily just simply, overwhelming infection. It could be a mild infection or maybe not even an infection altogether. But here, just simply the interconnectivity, the environment as a whole, the biofilm. It's a community of bacteria embedded in an extracellular matrix. Tumor microenvironment is an extracellular matrix component. And it colonizes different human cells and tissues, and this allows it to subvert the host immune reaction by preventing immune detection and polarizing the immune reaction towards an anti-inflammatory state, promoting the persistence of biofilm-embedded bacteria in the host. Take out bacteria infection and insert cancer here, and you're really talking about the same thing. So when you look at cancer, what we understand now is that there are bacteria within cancer that play a role in that tumor microenvironment in resistance to chemotherapy. And I would tell you there is biofilm there as well, and it's helping to evade the immune system. The biofilm plays a crucial role in prognosis and progression of various bacterial infections that are associated with short-term and long-term issues. And again, what it's primarily doing is it's disrupting the immune system. It's disrupting the communication of the immune system. And here, dealing with infection, it's going to be very similar in the extracellular matrix of a non-cancer situation as it's going to be in the extracellular matrix of a cancer situation. So there is significant connectivity here. There's significant similarities, and there's absolutely connectivity between infection, biofilm of infection, and the same in cancer. So I wanted to also expand your thinking beyond just infection, but also think, hey, there's this interconnectivity biofilm, which is usually just referenced to Lyme, Borrelia burgdorferi, but here it's actually being connected to many other infections, but I'm bringing it in to the connection of cancer. So here, of course, is talking about Lyme. It would be amiss without talking about Lyme in dealing with biofilm. Now, this was a very interesting in vitro study, and what they looked at is they looked at Lyme, Borrelia burgdorferi, in breast epithelial cells, and they found that, you look over on the right, the infected breast cell lines, the Borrelia burgdorferi, increased the breast epithelial cell growth and invasion and migration. So let me repeat that. In breast cancer cells, the infection of Lyme actually accelerated the invasion and growth and spread of the cancer's cell lines, here being breast. And the actual mechanism was this MMP9, or matrix metalloproteinase. This study also found that adding doxycycline with vitamin C, both treatments in Lyme disease, lo and behold, can eradicate cancer stem cells. So here we're talking about infection, Lyme, biofilms associated with Lyme, and then this study inadvertently is actually connecting it to the same, that's cancer, but also with treatment between the two, Lyme via doxycycline and vitamin C. So when you look at Lyme, specifically we have to talk about vitamin C, doxycycline. So vitamin C is effective treatment against active Borrelia, as I talked about here from this previous slide. Latent Borrelia, which is the bacterial causative agent in Lyme, it disrupts the biofilm and it augments doxycycline, turns around doxycycline, augments vitamin C, and it will kill the spirochetes. That's what Borrelia is. Combination of doxycycline with these compounds allowed for 50% reduction of antibiotic concentration, killing 90% of spirochetes. So the combination of vitamin C and doxycycline increase this destruction process of the Borrelia infection, but it also eradicated the biofilm. So the previous slide connected the biofilm of Borrelia burgdorferi and Lyme to really the similar process in cancer. Here, this is showing treatment is going to treat both effectively as well, and biofilm kind of being the interconnectivity between them. Not infection, but just that interconnectivity, that network that brings them together. It's kind of like a neighborhood. It's a subdivision. So when we look at biofilm and what it's doing, it's really inducing immune reprogramming, immune dysfunction, and metabolic reprogramming and dysfunction, typo, in the tumor microenvironment. So the biofilm in infection is going to be related to the extracellular matrix infection. Here it's also related to cancer. So the biofilm is really contributing to the process that allows cancer to grow, thrive, survive, and spread through immune disruption and metabolic reprogramming, all within that tumor microenvironment. So by altering the metabolism, it promotes that kind of altered oncogenic or cancer-promoting metabolism that so many people talk about, read about, speak about, the Warburg effect, sugar, cancer taking sugar, using it very aggressively, promoting lactate, the acid environment, all those things. But what it also does, it also disrupts the immune system, what's called immunoediting, which is the process by which the immune system either promotes or destroys those cells. So immunoediting is a very important process in how cancer cells will eventually evade the immune system and then lead to immune evasion, which is a critical step in how cancer spreads. And the reason why cancer spreading is so important, 90% of morbidity and mortality associated with cancer is when it spreads. So what we're dealing with here is the crosstalk between the immune system and the bacteria and the biofilm, the network, the subdivision. And this process is how the environment starts to change and set the groundwork, lays the platform for cancer to not just develop, but survive and spread. And it's doing it through so many things that I've talked about in other arenas and other areas, immune system disruption, but here we're talking specifically about infection and biofilm in the contributing process there. So when we think of infection, when we think of a patient with Lyme, most are just thinking about the symptoms and the debilitating disruption of life function associated with it, pain and depression and so many other things, which is all relevant, all important to consider. There's some great docs out there in the country and the world doing some great work there. But here, it's the preeminent step in really laying the groundwork for cancer to develop. And so when you look at patients that have had major infections in their life, you have to concern yourself with the impacts of that later on in life. And again, what's happening in cancer is the cancer draws the immune system to itself and then disrupts the immune system. These infection sources are starting this disruption and imbalance in the immune system even before the cancer process can really start. And so thus this crosstalk is critical and key to this process. So this is really interesting because we try to be as precision-based as we can in cancer treatment here at Brio-Medical. And what we do is we do a lot of very specific genomic testing, transcriptomic, proteomic testing, allow us to really dive deep into the behavior of a cancer. Recently I have a patient, she has no evidence of disease, breast cancer, and she's like, well, now what? So we did some testing and we're going to institute specific customized peptides for her based on her test results. Despite not seeing any disease, we want to take a step forward and really promote healing. And so the concept here is that the activation of the immune system, stimulating inflammation and promoting the scattering of tumor cells leading to distant colonization called metastasis, is really led by and can be led by infectious source. This slide right here is all those funny little things there in the inside the gut, not inside the body, but inside the gut, is representing bacteria and viruses and other things. And what happens is this chronic exposure, which could be dysbiosis, mycobiosis, imbalance, infection, they're going to trigger processes, nuclear factor kappa B, which I mentioned, inflammatory, interleukin signaling, and then FCG, BP, and MUS2. These are genetic alterations. These are enzymes. These are genes that get turned on or off. The FCG, BP, and MUS2 or mucin, these were two genes that were involved in the patient that we reviewed the results today. So what we have here is a connectivity between infection or dysbiosis or inflammation that can actually here come from the gut in this slide, in this study, and actually lead to genetic alterations systemically that can either cause cancer locally in colorectal cancer, anal cancer, but actually can be also connected systemically. All through infection or imbalance or maybe even biofilm. They didn't look here specifically at biofilm, but here it's connecting it to reality here today of the patient who I reviewed, and we're going to get her started on custom peptides here in about 4 weeks. So when we look at this microbe-mucus interface in the pathogenesis of colorectal cancer here, what they're seeing here is aberrant, abnormal mucin expression and glycosylation are linked to chronic inflammation, gastrointestinal cancers, particularly colorectal cancer. So what we have here is a connection to this concept of infection or inflammation as a result of that. Throw in biofilm, throw in imbalance, that would be dysbiosis, mycobiosis for fungi, and this is contributing to the changing of the environment that's going to allow cancer to develop and occur. But what we're looking at the last two slides is some of the mechanisms of how this process happens, some of the exact mechanisms. And this leads to unfavorable host responses, that's immune, and subsequent development of tumors. So the cancers implicated here include colorectal cancer, skin cancer, lung cancer, pancreatic cancer, esophageal cancer, cervical cancer, breast, ovarian, glioblastoma. So many different cancer types implicated as a result of the biofilm. Parasites. These are things that we just don't think about here in the U.S. much, but let me tell you what, they're a big deal. Now, we may not see a bunch of people walking around with tapeworms or liver flukes or things like that, but we see parasites quite regularly. And when you look at the types of parasites, again, the three most pathogenic as it relates to cancer, again, accounting for 0.4% of all cancers, Schistosome, Opisthochus viverni, and Clinorchus sinensis. These three are critical in contributing to the infectious sources of cancer. Another one would be Trypanosoma cruzi, and even malaria can be implicated. So this is a picture of parasites. Again, some of those implicated. There's those three that are labeled level 1 carcinogens, Trypanosoma cruzi, and then Plasmodium falciparum, which is malaria. And so when we look at the mechanisms of how this process happens, I love that graphic to the left showing those three, again, parasites causing, there's that word, inflammation, and driving metabolic oxidative stress, think metabolic change, physical damage, promoting wound healing. Cancer is often referred to as the wound that does not heal, leading to cellular transformation and proliferation. The inflammation leads to activation of signaling pathways. Nuclear factor kappa B, I've talked about that several times already. JAK-STAT, talked about that already. P53, that's a tumor suppressor gene that gets turned off. You get DNA damage, mutation. You get oncogenic activation, oncogenic signaling. You get cell growth, survival, proliferation. We have cancer. So this process is not theoretical. This process is understood. And in many ways, it's very similar to bacteria and similar to viruses, but slightly different than the biofilm. But we're not just theorizing here of the how. We're actually describing the mechanisms of how this actually happens. And again, even with something as relevant recently as the SARS-CoV-2 virus, we understand this process because it's repeating the same pattern that history has promoted as it relates to viruses. We understand that mechanism. And it doesn't just contribute to the cause of cancer, it contributes to the growth, survival, and spread of it as well. So cancer is implicated here: gastric cancer, cholangiocarcinoma, bladder, colorectal, squamous cell cancer. And this doesn't just have to be skin. This can be head and neck cancer, esophageal, hepatocellular cancer, which is liver cancer. This is a slide over to your right. Going back to medical school, just thinking back to some slide tests that we have, it's malaria. It's within red blood cells. So this is a slide that I actually presented down in Florida last week at the Vitamin C International Consortium Institute, looking at cholangiocarcinoma and cell viability. When you look at parasites, some of those flukes, liver flukes, lung flukes, cholangiocarcinoma, liver flukes are a contributor to cholangiocarcinoma. And here we're looking at high-dose vitamin C. What you see as you scroll across the dose down there at the bottom, 0.5 millimolars all the way up to 100 vitamin C millimolar. This is in the plasma. This is plasma ascorbic acid level. It has an anti-proliferative and pro-apoptotic effect of high-dose vitamin C in cholangiocarcinoma cell lines. So here's a cancer type driven by parasitic infection of which vitamin C treats. So not to say vitamin C is the only treatment, but what I want to show you here is not just infectious contributors and biofilm contributors, but also some slight mechanisms of how we might go after these treatments, after these processes with treatment. Same process looking here. Interestingly enough, I think this is important. When you look at cholangiocarcinoma, glutathione actually counters the anti-cancer effects. You heard me right. Glutathione counters the anti-cancer effects of vitamin C in cholangiocarcinoma. There's a lot of people out there that get vitamin C and glutathione, or vitamin C plus NAD, or vitamin C plus NAC in the treatment of cancer. And research is very clear. NAC, NAD, even glutathione will counter the anti-cancer effects associated. In fact, when you look metabolomically at what vitamin C does in cancer, it actually depletes glutathione and depletes NAD. This is just showing that one of the effects is hydrogen peroxide being increased by vitamin C. And this is just describing the mechanisms. Again, not just what, but the how of how vitamin C against cholangiocarcinoma. Again, typically very connected to parasitic infections, but it's altering these expression of apoptotic genes. It stimulates Bax proteins and downregulates BCL2. Fungal. Fungal infections often get ignored as contributors to cancer, but they're there. They're definitely a lesser of the tripod head, that is viruses, bacteria, parasites. The fungal would be the fourth. That's not tri, but that'd be quad. Here we're looking at fungal infections, toxins, so not just talking about infections, colonization, the microbiome. Everybody talks about dysbiosis, or the microbiome. That's the collective environment of bacteria in the gut or elsewhere. Here we're talking about microbiome, the collection of fungus as a biome. It's implicated in carcinogen in both animal models and human models. So this doesn't have to be acute infection, but can also be just toxins associated with it, colonization, and the microbiome. Fungi implicated here, not as dramatic, not as broad, lesser evidence here, but nonetheless still implicated. The cancers implicated: pancreatic, squamous cell carcinoma, oropharyngeal and esophageal, skin cancer, colorectal cancer. Interestingly, with the pancreatic cancer, giving antifungal amphotericin B has been shown to help reduce tumor size. So again, antifungal, implicating not just cause and effect, but also treatment. And again, it's not just infection, just very similar to the biofilm topic. Here we're just talking about the toxins that fungi can produce. And we do a lot of testing of that here in our office, because some of the most potent toxins known to man are mycotoxins. So for example, aflatoxin, food supply, is one of the most potent toxins known to man. Ochratoxin, which can come from food. So food that is stored improperly on the shelf, rice, grains, these kind of things that can stale with age. This is a fungal toxin. It's been implicated. It's a toxin, not infection. It's implicated in cancer. Zearalenone, the same. Fuminescence, penicillin toxins. So these are not infection, but actual toxins that play a role in causation of cancer. Now, also understand that many mycotoxins, like ochratoxin and zearalenone, these are also estrogenic. So these are toxins from fungi that can not only cause cancer, but also contribute to the growth, so say an estrogen-responsive breast cancer. But a fungus is contributing to the process in a multitude of ways in the process of cancer. The cancers implicated here: liver cancer, breast cancer, cervical cancer, colorectal cancer, and esophageal cancer. So what I wanted to do this time was just to present a little bit of a different approach, not so much deep dive in pathways, but really step back and say, well, what about causes, and what about a different view of cause related to cancer and infection, which is something that just doesn't get touched on much here in the U.S. as contributing to cancer, is a big player, again, up to 25% if you look at them collectively. And beyond just the concept of infection, we also have to, I think, consider that biofilms are a major driver here, not just as a contributor to the immune dysfunction, but also as a part of the process of cancer as a biofilm. We know that bacteria exist within cancer, in particular, bacteria exist within particular cancer types. This contributes to protection of the tumor, but wherever these species collect together, we know there's going to be biofilm interconnectivity to drive that process. So to learn more about who we are, what we do, and how we approach targeted tumor, customized, precision-based through the field of omics to drive holistic natural healing in the treatment of cancer, call us to schedule an appointment or share this video with others that you think may benefit for this, in this concept of infection contributing to cancer, because cancer is not going away. The last 2 years is really going to show us that this is going to continue to drive further increase in the incidence of cancer, not just in the U.S., but worldwide. So thank you very much. A little bit shorter today, and a little bit take on how we approach this for a webinar. Just trying to get, trying to fit with the concept of doctor, and the word doctor in Latin means teacher. So empower you through knowledge, to be aware, to be informed, to basically take control and drive your health and wellness potential. So if there's any questions, good question. Is there a way to test biofilms that contribute to cancer process? No, there's not. What we're talking about here is really just the scientific research that clinical's not been able to catch up to. And it's a great place to be because it allows us to be aware that it doesn't just have to contribute to infection. So when new patients come in, we always take an extensive history of prior infections, prior exposures. I mean, we have a patient here right now that's had 5 different primary tumors. Now, he did a lot of flying. He worked in an industry where he's exposed to a lot of toxins. But so looking at those things, a lot of people think of, but we also have to consider infection. We also too have a patient here that has 2 primary cancer types, one in the breast, one in the pancreas. We tend to see more patients dealing with really rare things, though we like to see things that are more straightforward, but we do see a lot of the rare, more difficult situations, and we see really good results there. So we're not at that point where that has met the arena where we can actually clinically test this. It's like what we talk about with all the metabolic changes and immune changes in the tumor microenvironment. There's actually no clear way to actually evaluate the tumor microenvironment clinically. We don't know. We just have to extrapolate what we know from the blood, what we know from animal research to the environment there. But we know that's correct, and we see that clearly with the SARS-CoV-2 information and how cytokine storm is what led to death and damage, and that it actually exists. I wanted to know if it was possible that I got a bacteria from the mononucleosis, Epstein-Barr virus, in my early 20s that I've struggled with and that now diagnosed with CLL. But, that's a very, very good question. What does the research say there? And that's what I always say. Don't speculate. Let the research lead the way. Research says yes. So what I've done here is talk about infection, not diving deep into each infectious contributor, but just kind of paint a general concept. But absolutely, this Epstein-Barr virus could have played a role, especially if it triggered immune dysfunction. And that's what often happens here, is it triggers immune dysfunction that persists. Again, I presented some other quotes from other studies talking about this, particularly the one talking about parasites, how the parasites triggered chronic inflammation. And that triggered the process that eventually led to cancer. So yes, here particularly leukemias, lymphomas, Epstein-Barr virus can play a role and could have played a role in yours. Now, as I mentioned in the beginning, sometimes you can't prove cause and effect in terms of playing armchair quarterback here, but research points to that connection. So the answer is yes, it could, but can we prove that definitively? No, we can't. But as a virus works to evade the immune system and grows rapidly, cancer cells will do the same thing. So I hope that answers your question. So absolutely. So when we approach a treatment, whether that be lymphoma, leukemia, that we consider Epstein-Barr virus as being a possible contributor to, our therapies are guided specifically towards that process. So for example, ozone, UVBI would be a part of this process, mistletoe. But again, we try to be even more precision-based than that through the genomics, epigenomics, transcriptomics, proteomics, etc. As I mentioned with the patient that I reviewed the results with today, where we're developing customized peptides for. When you think about infection, a lot of people talk about HPV, and that is definitely a contributor. And so when you think about this, is not just something that we think about in adulthood. Usually these go back to our younger aspects of life. So they're saying that I am in watch and wait phase now. They're not going to do anything for me, and I'm scared that, well, first of all, don't fear, okay? Fear will suppress your immune system. It's about hope. Hope is a confidence in a future. That's what the word means, confidence in and for a future. So what you want to do is, from a conventional standpoint, they're waiting for cancer to become aggressive. They're waiting for cancer to spread. There's no reason for that. That's like you see smoke coming out of your car and you say, let me just wait till the car stops and the car won't run. If you ever take your car and you get it repaired and you've done that, the car repairman is going to chew you out, rightly so, because you've damaged the engine irreplaceably. Likewise, here, our bodies are the only car, the vessel we got. This engine is all we got. And so absolutely you should not wait on things to get worse. You should jump in on it, because there are absolutely things you can do to really slow the tide and really promote an environment of healing, and not wait till things go off the rail, wait till things really fall off the cliff. I mean, we had a patient here not too long that had CML, and they wanted to wait. It progressed to AML, and things just went back and south really fast. So cancer is not something you play around with. It's something that you go after. And here, prevention and early treatment is always the key. So treatment strategy should be one that really targets the process ongoing, as well as the potential contributors here, and that would be viral Epstein-Barr virus. That's why question then went on, why are they waiting till I have full-blown cancer? It's what, Diane, it's what they're trained to do. It doesn't make it right. It's just what they're trained to do. Doesn't mean they're bad doctors too. That's very important to understand. There's lots of good doctors that are conventional docs, so I'm not bashing them. In fact, one of the things I always try to do is reach across the aisle. It's just what they're trained to do, and it's how they're trained to think. Doesn't make it right. That's just understanding it what it is. It's just hard when you're sitting there wanting to do something and they're telling you there's nothing to do. In fact, when there's plenty you can do. Ozone, vitamin C, vitamin D, work on the gut, figure out what's going on with the gut, identify the immune system, and work within that concept. All of these things are significant impacts of treatment that can be added to a program for you to really go after that. Now the problem is you're not going to find that with a conventional doc. You're going to have to look to an integrative doctor to be able to do that. How to talk to your oncologist about that. That's a tough one, Diane. What I would say is be your own advocate. Doctors we work for our patients. So if you have a relationship with a doctor and they don't give you the care or direction that you feel is best for you, you are obligated to leave and find another doctor. You are not obligated to stick with any doctor. This is a unique relationship. And you need to recognize that you are the one in control. It's about you. If you don't feel the doctor or doctors or providers are providing that focus, attention, and detail and planning that fits you, then find somebody else that will. Find somebody that will listen to you and be open to how you're thinking and proceeding. You're not stuck in that relationship. So what I would say is see if there's some integrative practitioners out there that, though they might not want to quote unquote treat you for the cancer, they can treat you with healing therapies, inflammatory reducing therapies like vitamin C, which we know reduces IL-6, interleukin-6, cytokine storm. It turns off nuclear factor kappa B. I'm not making statements here that are unsubstantiated with science. The science tells us that. When you look at some of the COVID sepsis and sepsis research, vitamin C, it inhibits that cytokine storm. So maybe here staying with your oncologist and continue to try to communicate with them, but also find an integrative doctor that can work in that other area, reducing inflammation, working to change the terrain, change the environment, like I mentioned with ozone, vitamin C, vitamin D, nutrition, gut, these other areas. Yeah, when he's talking about radiation there, Diane, it's what they know. It's what I tell people. If you go to a orthopedic surgeon because of a knee ache, don't be surprised if he recommends surgery. It's what they do. It's what they know. It's what they do. If you go to an orthopedic surgeon because you got a knee ache, he's going to probably recommend surgery. It's just it's how they're trained to process. It's how they're trained to think. One of the things that I want to do, and I think it's very important, is to provide patients with information that empowers them with the ability to make decisions. Yeah, well, I'm glad it's helped you to understand better, Diane. These are difficult concepts that even that are all in the research, and a lot of conventional docs don't know about because they just don't read it. They've done studies looking at docs, and docs just don't read. They don't read. But what I've noticed is that patients want details. They want deep dives. They want specifics because it empowers them to understand what's going on. But in that, it empowers them to act. It empowers them to make the right decisions when they're with their doctors. It empowers them to make the right decision in the doctors that they find. So everything about healthcare, medicine, it's about the patient. Medicine should be an advocate for a patient only, nobody else. Not for insurance companies, not for hospitals, but for patients. If we're an advocate for patient, we're doing our job. The problem with a lot of today, and you're kind of alluding to this without directly calling it that, Diane, is docs are not advocates for patients only. They're for a system, a protocol, bureaucracy. Yeah, I won't mention the state, Diane, but I am not aware of that at all. I did have a patient one time that came in with a 27 centimeter non-Hodgkin's lymphoma mass. Literally, she came in a wheelchair because she couldn't walk because she had edema from her feet to her breasts. She ended up losing 75 pounds with us of weight, and it was all fluid. And she left with a scan that was clean. She had a 27 centimeter mass when she came in, and that was creating all kinds of obstruction. That's where all that edema came from. She was with us for 10, 11 weeks. I can't remember. It's one of those two. And she left without any mass. And she went back to Maine. She lived in, said that, but she went back to Maine and was not able to find any integrative cancer center there. Well, I hope this has been a little bit of some good information for you, empower you, provide some stimulation for learning, and we'll try to do these every 2 to 3 weeks. I haven't come up with a topic for next time. So if any additional questions come up, please do reach out to us. You can reach out to us in all the social media means. Also, if you have any topics of interest that you would like us to address on a future webinar, reach out to us and make some suggestions there. So I hope everybody has a great rest of your week and a fantastic weekend. Fall's right around the corner, so hopefully we'll get some cooler weather. And that's exactly what we're getting here in the great sun state of Arizona, though it's still hot. So you guys have a great day, and we'll chat soon.